I'm Dr. Fakir Averi, and this is Travel Medicine and Immunizations. Travel medicine and immunizations go hand in hand. There are some immunizations that are only indicated when traveling, while other immunizations are indicated whether traveling or not. As you can see from these stats, international tourists have exceeded 1.2 billion persons, and depending on the destination, 22 to 64% of travelers report some illness. Now, most are mild and self-limited, such as diarrhea, respiratory infection, skin disorders, etc. And some return to own countries with preventable life-threatening infections. Yet 20 to 80% of travelers do not seek pre-travel health consultations. Now, here are some examples of mosquito-borne infections, also food and waterborne infections, other viruses, tick-borne infections, animal-borne infections, and other issues that travelers may encounter. The ones that are bold are actually the topics that are covered in this presentation. The syringe symbol shows that there is some sort of immunization, either PO or injectable, available for these infections. Vaccination is perhaps the easiest and the most successful way to prevent disease. Generally speaking, we have two types of vaccines. One that's considered live attenuated vaccine, or LAV, and also we have a majority of vaccines are available as inactivated vaccine. So here's a list of different vaccines, and they are broken into two types: the live attenuated vaccine and inactivated vaccine. It's important to know what type of vaccine a particular vaccine is, because it makes a difference when it comes to storage, for example, as well as other issues. For example, live attenuated vaccines cannot be administered to patients who are pregnant or immunocompromised. But when it comes to storage, vaccines that are live attenuated, they need to be stored in a freezer, whereas the rest of the vaccines can be stored in the refrigerator. So the most important vaccination that you will encounter as a pharmacist is the flu shot or influenza vaccine. It's important to know that the flu season in the US goes from November to April. So typically the influenza vaccine should become available by October, and that's when you want to start immunizing your patients in October and throughout the flu season. To give you some background about the influenza virus, is that it's probably been around for the past 400 years. It's not a new virus. Influenza, in general, we have three types. We have influenza A, influenza B, and influenza C. One discovery that was very important was the discovery that influenza virus could be grown in eggs in 1936. Because of that, we were able to develop influenza vaccination. And that's also important to know, because we will talk about egg allergy And it's just knowing that these vaccines are developed in eggs will help you understand why egg allergy becomes an issue. So as I mentioned, there are three different classes of influenza virus: influenza A, B, and C. Generally speaking, respiratory tract infections can be divided into upper respiratory tract infection and lower respiratory tract infection. Lower respiratory tract infection is a more severe because it involves the lungs and the bronchi, and because of that, the infection will be more severe. So between the three types, influenza C typically causes infection in the upper respiratory tract, which is more similar to the common cold. The common cold is an upper respiratory tract infection. And influenza A and B typically cause lower respiratory tract infection. And influenza A and B are the ones that we actually target in the vaccine because they can cause a more severe infection, which is similar to pneumonia. Pneumonia is also an infection of the lungs and the lower respiratory tract infection. So we will, focus on influenza A and B. So just a quick overview of the structure of the influenza virus, and this picture is focusing on influenza A virus. There are some differences between influenza A and B. What you need to know is that there are certain proteins in the virus that are essential for the virus to function. One of them is hemagglutinin, or HA or H, which you can see is over here. The function of HA is for viral attachment. So without this, the virus cannot attach to the host. So it's essential for the virus H. There are at least 16 distinct different hemagglutinin proteins, and they are labeled H1 through H16. So if you've heard of H1N1 virus, for example, the H1 is referring to the type of hemagglutinin that the virus has. Another protein that's essential for the influenza virus is neuraminidase, or N, and there are also 9 distinct types of neuraminidase labeled N1 through N9. And then we also have the M2 protein, which is unique to the A virus. But in general, you just need to understand what hemagglutinin and neuraminidase are, because it will help you understand the nomenclature for the vaccines and the virus. So let's take a look at the nomenclature. So when we talk about different strains of influenza virus, the first thing that you see in the nomenclature is the influenza type. So influenza A, B, or C are your options. So here's an example on the right hand side. So the first letter is referring to the type of the virus. Next, they talk about the place of initial isolation. So for example, in this example says A slash Fujian, which is the geographic location of this particular strain. And then they talk about the strain designation. So next, it follows a number. It's just a number that indicates the strain of this particular virus. And then they put the year of isolation or discovery. So in 2002 is when they discovered this particular virus. And then for influenza A specifically, they also put depending on the hemagglutinin and neuraminidase, they also put the numbers for. So for example, H3 and 2. And here are some other examples for you. So for example, the influenza A virus isolated by Francis from a patient in Puerto Rico in 1934 is given the strain designation A slash Puerto Rico slash 8 slash 34. So 34 meaning the year 1934. And back then they didn't have the technology to classify H and N, so older strains don't have that designation, whereas newer designation, for example this one in 2002, has that designation. Here's another example. Pandemic H1N1 influenza A virus that was discovered in 2009 in California is designated as strain A slash California slash 7 slash 2009, and then in parentheses H1N1. So this is the nomenclature. So you just need to understand. You don't need to memorize any of these names. Just be able to understand what it means when you see a specific name of a strain. Now here's a quick introduction to diphtheria, tetanus, and pertussis. So here you can just see, these are three different diseases caused by three different species of bacteria. They typically affect children, but they can also affect, adults throughout life. So, I will talk about recommendations that you typically need to get a TD shot every 10 years. But here's what these diseases can cause. Diphtheria is spread by respiratory droplets or physical contact. And it can cause a buildup in the throat or nose, making it difficult to breathe and swallow, so as you can see in this picture. Tetanus causes spasms of the muscles of the jaw, which typically is referred to as lockjaw. Clostridium tetani is the organism that causes it, and is typically found in the soil, dust, and manure, and is an important organism to consider, especially if you step on a let's say you step on a rusty nail, or similar cut on the skin that will introduce these organisms from dust or the environment. And then lastly, pertussis, or the whooping cough, is a respiratory disease. It damages the airways, so it makes it difficult to breathe. And these are diseases that can be prevented. So we'll talk about the actual vaccination. Next, we have herpes zoster, which is a painful condition resulting from reactivation of varicella zoster virus, or the chickenpox, from latent state in sensory nerve ganglia. Typically, it's unilateral. So if you see these lesions, you can see that they're either side of the body, and they cause rash and blisters that typically scab over in 7 to 10 days and clear like within 2 to 4 weeks. Human papillomavirus, or HPV, is another one that we have vaccines for, and this one is important to know because it can cause several cancers. So because it can cause several cancers, we have vaccination, so we target quite a few strains of the HPV virus, and we'll talk about which ones in particular. And of course, here are some reliable resources. So when it comes to guidelines for immunization, the CDC is the place to go. So the CDC updates immunizations at least once a year. So definitely every February of each year, they will release schedules, immunization schedules for children as well as for adults. So that's definitely annually, but also throughout the year. If there's something in particular that they need to update, they do. So whether there's a new vaccine, or if they, because of new data, if they change their recommendations, they will update portions of their recommendations. But definitely at least once a year, they update the entire schedule for children and for adults. For more, of course, these are the common immunizations that's the CDC recommends. If when it comes to traveling and vaccinations that are not common, you can refer to World Health Organization for recommendations. Also, when it comes to travel medicine, there is an interactive graphic that you can access on the New England Journal of Medicine's website, which, depending on where your patient is traveling to, you can see what kind of diseases are common in that particular location. So, this is not something that you can just memorize and know off the top of your head. So that's why it's good to know these resources, because if someone comes to your pharmacy and asks, for example, I'm going to, you know, South Africa, and what should I worry about, and how can I prepare for my travel there? You can easily pull up this interactive map, and it will tell you, along with the recommendations on how to educate your patient. And then there's also the Immunization Action Coalition that will give you a lot of resources, including patient handouts for different vaccines. And also, when it comes to reporting adverse events that are caused by vaccination, the vaccine adverse event reporting system is where you want to go to report any adverse effects that a particular vaccine has caused. Or if you want to read about reported adverse events, you can also go here for a report. And it's available for free. Alright, so our first learning objective is recommend appropriate primary prophylaxis measures for a patient at your outpatient pharmacy traveling to an area where mosquito-transmitted viruses are endemic. Now, these are mosquito-transmitted viruses. So the most recent one is the Zika virus, which is a single-strand RNA positive sense virus. It's primarily transmitted by Aedes aegypti and also Aedes albopictus, which are two species of mosquito. So these two species of mosquito are like the most common one. I can see that other viruses, including chikungunya and dengue and yellow fever, are also transmitted by these two species of mosquitoes. They are known for biting during the daytime. So there is no risk overnight when people are sleeping from these two species. Now, Zika specifically is also transmitted vertically from mother to child. There are also reports of sexual transmission, as well as transmission through transfusion, as well as organ transplantation. Now, the incubation period for Zika virus is about 3 to 12 days. That means once someone is exposed to Zika virus, it takes 3 to 12 days before they have symptoms. Now, outside of incubation period, I have also listed how long the virus stays around, for example, in the blood. So in the blood, the virus will stay for 3 to 5 days. So this is important to know, because if you are to diagnose the patient, you only have 3 to 5 day window to detect it in the blood. Now, more recently, we have found that it actually stays around longer in the urine. So urine tests are actually more ideal, because you have a larger window for diagnosing it. So 10 to 20 days. Now, in the semen, the Zika virus is reported to stay for several weeks. Latest reports suggest that it may actually stay in the semen for longer than 2 months. So that's important to know, if you are to make recommendations to patients, and if someone has been exposed to the Zika and they want to plan pregnancy, then you want to advise them to delay their plans by at least 6 months, just to be sure. Now, chikungunya, also transmitted by these two mosquitoes, and incubation period is about 3 days. And we don't really have vaccines available right now, primarily because lack of interest and funding. There are vaccines in development for Zika virus. The next virus is the dengue virus. with the incubation period of 5 to 7 days. There is one vaccine available for dengue outside of the United States. So this is available in Brazil, the Philippines, and Mexico, but not in the United States. So if patients are traveling to those areas, they can actually get the vaccine over there. Now for yellow fever, um, the two Aedes species of mosquito will transmit, as well as the Hemagogus species of the mosquitoes, which also bite during the daytime. We do have a vaccine available for yellow fever called the yellow fever vax, and I will talk more about that later. Last, we have Japanese encephalitis virus, which is actually transmitted by the Culex species of mosquitoes, which bites at nighttime. Incubation period is 5 to 15 days, and we do have a vaccine available for Japanese encephalitis virus called the uh, Ixiaro. Now here are the two most common Aedes species of mosquitoes. Now in the United States, you can see that these mosquitoes are common in the south regions of the United States. More commonly in Florida is known for being the Zika zone, as well as Texas and southern regions of California. And then worldwide, of course, south regions of the US, as well as Central America and South America, as well as a large portion of Africa and Far East Asia. These are where the Zika virus is endemic. Now, when you compare the symptoms of chikungunya, Zika, and dengue, because these viruses are pretty much related through evolution to each other, including sharing the vector for transmission. One thing that stands out is that when it comes to thrombocytopenia, note that dengue is actually known for high intensity thrombocytopenia. So it's important to know, because these are pretty much, this is called the dengue fever. Zika will cause fever, chikungunya will cause fever. So one of the things that patients will need is treatment for fever. So for dengue specifically, it's important to avoid aspirin and NSAIDs because of the risk of bleeding due to this high intensity thrombocytopenia caused by the virus itself. Now, Zika and pregnancy. Infection during pregnancy, and the latest data suggests it can be at any trimester, can cause birth defects called macrocephaly. So you can see in this picture, this is a normal size of the head in a newborn, and then you can see through macrocephaly there will be growth retardation of the brain and the head. So this is an actual picture of a baby that was born with a macrocephaly associated with Zika infection. Now, among all these viruses that I mentioned so far, Zika is the only one that is actually known to be teratogenic. Now, let's look at the management of these infections. So for the Zika, there is no specific treatment. Treatment will primarily be supportive care, hydration. It is important to use APAP for fever, and avoid aspirin and NSAIDs if Zika has not been confirmed, because presentation could be just like the dengue virus. So if you don't know for sure if it's Zika virus, you should avoid aspirin and NSAID because it could potentially be dengue. So you don't want to risk bleeding in the patient. Antihistamines for cutaneous symptoms, and of course rest. As far as prevention, it is important to postpone pregnancy by at least 6 months. It's actually suggested to delay by 2 years, which can be difficult, but definitely at least 6 months. And it goes back to what I mentioned about the virus lasting in the semen for probably more than 2 months. So it would be safe to postpone pregnancy by at least 6 months after exposure or potential exposure. Other things that can help with prevention is using air conditioning, screens or nets, wearing long sleeves and pants, permethrin treated clothing, insect repellents, eliminate standing water containers, and use condoms, since it is also sexually transmitted. For chikungunya, also no specific treatment. Supportive care is recommended. For the fever, NSAIDs can be used in chikungunya because we don't have the risk of bleeding. No specific vaccine, so as far as prevention, basically avoid exposure, including many of the measures for preventing Zika virus applies to chikungunya as well. For dengue fever, no specific treatment. This is extremely important to use APAP for fever and avoid aspirin and NSAIDs, as I mentioned. And no specific vaccine in the United States. There is a vaccine outside of the US that could potentially be used. So best thing for prevention is to avoid exposure, including many of the measures that I mentioned for Zika virus. Now for yellow fever, also no specific treatment. We do have the yellow fever vax, which should be given at least 10 days prior to travel to a yellow fever endemic region. It is a live attenuated vaccine. It's a single dose. Patients can experience local site reactions. And because yellow fever vaccine is made in the egg, it's important to assess the patient for eggs allergy, as well as gelatin allergy and latex, because there is some component of latex in the vaccine. Now, Japanese encephalitis virus, also no specific treatment. We do have a vaccine available that should be given at least 7 days prior to travel to a Japanese encephalitis endemic region. It is an inactivated vaccine. It is a 2-dose series given 28 days apart. So the second one should be given at least 7 days prior to travel. So you can imagine 28 days before the 7 days would be the first dose. Now, it's only recommended if someone is traveling to a Japanese encephalitis endemic region and they're planning to stay for at least 1 month. So if they are to stay for less than 1 month in that area, it's not recommended to use the vaccine. Now let's take a look at this interactive graphic. Now when you click this link, it will bring you to this article called Medication Consideration Before International Travel, published in New England Journal of Medicine. And if you look over here, there's the interactive graphic. If you click it, it will open this, and you have different tabs, and one of them is geographic disease distribution. So here's a map of the world, and then you can choose which infection you're interested in. So for example, chikungunya, if you click on chikungunya, you can see what areas are endemic for chikungunya. You can also zoom in and out. You can also click, for example, the Japanese encephalitis, or you can unclick chikungunya. So here's the areas where Japanese encephalitis is endemic. Let's see what else. Yellow fever, here's where the yellow fever is endemic. And last but not least is the Zika virus. So this is an excellent tool that you can use, which is available for free. Alright, so when it comes to insect repellents, we have several options available. Note that all of these options are safe for use during pregnancy, and also if there is concern for animals, DEET is also been reported to be used safely in dogs. DEET can repel mosquitoes and ticks. Now, concentrations greater than 50% does not improve efficacy. And as far as repelling ticks, at least 20% concentration is required. One of the things about DEET is that it can damage clothes, including synthetic fibers, and it can also damage plastics on eyeglass frames and watch crystals. Now, picaridin also repels mosquitoes and ticks. A concentration of 19.2% is as effective as long-acting 33% DEET. It is odorless and non-greasy. These can be greasy, so that's something that patients may complain about. So if they do, you can switch to picaridin, which is non-greasy. It does not damage fabric or plastic, and but it can discolor leather and vinyls. We also have other options that are, really not as effective. But the last option that's pretty effective is permethrin, which can repel mosquitoes and ticks and also kill them. So this is something that we use on clothing, mosquito nets, tents, and sleeping bags. So it's basically you treat um, these items using permethrin. Now, permethrin remains active for several weeks through multiple laundry sessions, so that's good. It should not be applied directly to skin, so only treats clothing or other items, but do not apply it to skin. Uh, Pre-treated backpacks, boots, and sleeping bags 24 to 48 hours in advance and allowed to dry. So before traveling, at least allow 24 to 48 hours. Um, and then you also need to retreat using permethrin according to the label instructions. So the bottom line is that wearing protective clothing treated with the insecticide permethrin, in addition to using DEET or picaridin on exposed skin, may provide the best protection. Now, when it comes to providing patient counseling, here are a few points. So one is that the agent's duration of action and need for reapplication is important to be discussed with the patient. Application of sunscreen 15 minutes before the repellent if needed, and sunscreen repellent combination should be avoided. So it's recommended do not use products that have combination of these with the sunscreen. The third item is give instructions to spray the product in the palm of the hand and then apply it to the face. The importance of not applying repellents to skin beneath clothing, so only apply to naked skin. Because if you apply it to the skin under clothing, it can cause irritation. Awareness of the product's expiration date is very important. And also caution with use in young children. So just follow the package labeling when it comes to using it in children. And last is damage of plastic and fabric by some products. That's important to be discussed with the patient. The next learning objective is, given a patient traveling abroad, identify causative organisms, symptoms, prevention, and treatment of food or waterborne infections. So in general, there are three common infections that could be due to food or waterborne infection: hepatitis A, cholera, and typhoid fever. For hepatitis A, we do have vaccines available. There is also one vaccine available in the United States. That's a live attenuated cholera vaccine, and it should be given at least 10 days prior to travel to a cholera endemic region. Again, you can use that interactive graphic to see what areas are endemic for cholera and also for hepatitis A and typhoid fever. We do have two vaccines available for typhoid fever. So one is an oral live attenuated vaccine, and the other one is a intramuscular injection, which is a killed vaccine. So the typhoid fever is caused by bacterium Salmonella typhi. An estimated 5,700 cases occur each year in the US. Both ill persons and carriers shared Salmonella typhi in their stool. Stool sample is needed for definitive diagnosis. Symptoms include fever, weakness, stomach pain, headache, loss of appetite, and rash of flat rose-colored spots like you can see in this picture. The next learning objective is, given a patient at your outpatient pharmacy getting ready to travel to Colorado to climb Mount Elbert, Identify prophylaxis measures and treatment for high altitude sickness. So what exactly happens at high altitudes? So high altitude illness, there are three different kinds. The acute mountain sickness, the high altitude cerebral edema, and the high altitude pulmonary edema. So these happen like in order, and they also get more severe. So high altitude pulmonary edema is a lot more severe than just the acute mountain sickness. So in this picture, you can see that in the alveoli, that's where the oxygen exchange occurs, and this basically works based on normal oxygen levels. What happens at high altitudes? So, for example, at an altitude of 4,300 meters, the partial pressure of oxygen is a lot lower than at sea level. So because the normal lung function is based on normal oxygen levels at higher altitudes, the lung basically will not be able to have enough oxygen. So what does that mean? Uh, So first of all, this will depend on several factors. So the terminal altitude, so the higher the altitude, the more severe that the high altitude illness is. Also the rate of ascent. So if you ascend very quickly, the body cannot compensate for the drop in oxygen pressures. So that would cause more severe high altitude sickness. The time spent at maximum altitude. So it's recommended to not spend once you get to the highest altitude, just don't stay there for too long, because the longer you are exposed to that low oxygen concentration, the more likely that the body will, progress into a more severe high altitude illness. And also the altitude when sleeping. So when sleeping at low oxygen levels, that can also lead to more severe high altitude illness. Now, in general, acute mountain sickness occurs in at least 25% of people who ascend rapidly to an altitude of 2,500 meters, and in most people who ascend rapidly to 2,800 meters or higher. So you can imagine at 4,300 meters, you're a lot more likely to have acute mountain sickness and potentially more severe forms of high altitude illness. Now, patients who are exposed to reduced oxygen concentration gradually are able to compensate, and this process is referred to as acclimatization. So through acclimatization, there's increase in ventilation and PaO2. There are also circulatory changes. There is hematologic changes such as increase in hemoglobin level. There's also oxygen delivery and utilization. So there's muscle atrophy, there's angiogenesis, and nitric oxide synthesis. So all these compensatory mechanisms will help prevent high altitude sickness. So the therapy for high altitude illness is descent to a lower altitude, typically at least a 300-meter reduction in altitude, administration of oxygen, which is usually not available on the field, but if someone can make it to a center where they have oxygen, that would be ideal. Also acetazolamide, dexamethasone as an alternative to acetazolamide, and nifedipine for treatment of high altitude pulmonary edema, because nifedipine can cause vasodilation in the pulmonary veins. For prevention, it's recommended to have gradual ascent, pre-acclimatization, avoid moderate to heavy alcohol intake during the acclimatization, avoid sedative hypnotics during the acclimatization process, avoid opioids. Of course, opioids can cause respiratory depression, so that's why it's recommended to avoid opioids during ascent. Also, acetazolamide can be used to prevent high altitude illness, and dexamethasone as an alternative to acetazolamide. And here's how the acetazolamide work. It is a carbonic anhydrase inhibitor that reduces hydrogen ion secretion in the proximal renal tubules and increases renal excretion of sodium, potassium, bicarb, and water, leading to metabolic acidosis. Now, this metabolic acidosis leads to compensatory hyperventilation and increased oxygenation of the blood. Here are the side effects for acetylzonamide, and here's the recommended dosage for it. Um, if someone has allergies to sulfonamides, acetylzonamide should be avoided in those patients. Now, this is just an example, an actual mountain in Colorado with elevations about 4,400 meters. So this is typically where people are very likely to have high altitude sickness. Now, one thing that's interesting is that in 2017 they actually conducted a survey of hikers in Colorado. They found that about 47% of patients failed to well, I shouldn't say patients. 47% of hikers failed to identify the defining characteristic of acute mountain sickness, which is headache, and along with a couple of other things that they found in the survey, which means that there's a huge opportunity for pharmacists to provide education to these hikers who, may not know this, how to deal with this. So. The next learning objective is given an adult patient's immunization history, recommend any additional vaccines that may be indicated for the patient given their age and comorbidities. Now here's a list of the vaccines that we're going to cover today. During cirrhosis, we will also talk about hepatitis B vaccine. So the most common vaccination that you will see as a pharmacist is the flu shot. So what exactly is in the flu shot? So the flu shots that are currently on the market, we have trivalent and quadrivalent influenza vaccines. So what it means is that, remember from earlier that I said there are three different types of influenza virus, type A, B, and C, and we typically target A and B in the vaccine. And we cannot just include every strain of the flu of the influenza. It's just impossible. So we typically include either 3 or 4 strains. Now every flu shot definitely includes 2 strains of the A virus, and they also include either 1 B strain or 2 B strains. So when it comes to evolution of the influenza virus, the B virus has basically branched into 2 lineages. So we call one of them Victoria lineage, the other one is Yamagata lineage. So in the 2017-2018 season, we have the Victoria lineage in the trivalent, and what's highlighted yellow is what you get in addition to what's in trivalent. So you get one more strain in the quadrivalent. So you can see that you get the Yamagata lineage in the quadrivalent vaccine, which is basically the same thing that was used last year. Actually, for the past 2 seasons, we've had the same Yamagata strain. When it comes to the Victoria lineage, you can see we are definitely we've been using the same strain. Actually, went as far back as 2010. We have been using the same Victoria lineage. There hasn't been a whole lot of change when it comes to the Victoria lineage. So we basically give the same coverage every year. Now you still need to give it every year, even though it's the same strain, because the immunity to it, wears off as time goes up. So the next year, you still need to get another shot. Now, one thing that they changed this year from last year, because pretty much the H1N1 from California that was endemic in 2009 has been the first A strain in the flu shot every year. Now this year they changed that to the same. I mean, it's still H1N1, but it's a different strain that was originated from Michigan. So That's what they have included this year. And the way they come up with it is that they use computer models to predict which strains are more likely to be common in the flu season. So there's no real way to know if this will actually work until this flu season is over, and then they actually measure to see how well it performed. But prior to the actual flu season, there's no way to know how effective they will be. Now, you don't need to memorize any of this. It's just you just need to understand the difference between trivalent and quadrivalent. So the trivalent, the season includes 2A strains plus one Victoria lineage, and the quadrivalent has everything that's in the trivalent, but in addition, it has a Yamagata lineage. Now, here are the CDC recommendations for this year. So the annual season influenza should be given to everyone 6 months of age and older. It doesn't matter which one you give them. So, definitely it would make sense that quadrivalent would give you more protection, but the CDC says it doesn't matter which one you give to your patient because they want more people vaccinated. So if they were to prefer quadrivalent, you may run out of vaccines, then it can cause that you may not be able to vaccinate as many people as possible. So primarily just because they want to vaccinate as many people as possible, they say it doesn't matter if you use trivalent or quadrivalent as long as you give it to them. One thing that's changed last season is that we no longer recommend live attenuated influenza vaccine. And that is because, over at least 2 seasons, it performed inferior to the inactivated vaccine. So because it performed inferior to inactivated vaccine, it is no longer recommended, and I believe it's not even manufactured anymore. Just because it's not recommended, so nobody's going to use it. So manufacturers are not manufacturing it. Okay, so for children 6 months through 8 years, there's more criteria. So if it's the first time the child is getting the flu shot, they should get 2 doses, and the 2 doses need to be at least 4 weeks apart. If they've only had in the previous seasons only one flu shot, in their life, then they also need two doses. That is to make sure that they get optimal protection. Now, if they've had if the child has had 2 doses in the past, it doesn't have to be in the same season. It doesn't have to be in 2 consecutive seasons. But as long as they've had 2 doses in the past, then you just go back to just give 1 dose annually. So otherwise, you just need to give 2 doses in the same season and have them 4 weeks apart. Now here's the thing with egg allergies. So majority of these influenza vaccines are developed in eggs. So you might say, what if a patient has egg allergy? And it used to be that if someone had egg allergy, they wouldn't give it to you. In fact, it's one of the questions on the questionnaire that you give your patients. You ask if the patient has had an egg allergy. And here's what the CDC recommends. So they say it depends on what the reaction was. So if they had hives to the egg, this is not to a vaccine. This is just to eggs. So if somebody, was eating eggs and they developed hives, they said it's okay. You can give them any licensed vaccine. It can be, as long as it's inactivated. Because we do not give live attenuated to anyone. So they say you can give any licensed vaccine. But if the reaction has been more severe, as in if they needed, like for example, epinephrine, because they were having anaphylactic reaction, they say even then you can still give it to them, but it has to be in a medical setting. so whether it's in an outpatient or an inpatient setting, so that a medical staff can be you know present in order to give epinephrine should the patient need it. It's probably unlikely that they will react to it, but you just have to. But nonetheless, you can give any of these licensed vaccines. It doesn't matter. So most of these inactivated vaccines were developed in eggs. So if you really are worried about your patient, there is also recombinant influenza vaccine. So this one is different. Recombinant uses recombinant DNA technology to develop the virus. So it's not developed in the eggs. So it eliminates that need. Now the reason CDC says for egg allergy to use any, they don't say just to use recombinant influenza vaccine, which would theoretically be safer, is because they want you to vaccinate as many people as possible. So if they limit it to this, then it's possible that fewer people will end up getting the shot. Just in case these are not available. Now, what if someone has had an allergy to an actual flu shot? Now, this is considered a contraindication. This is a different story. So this is not a reaction to an egg. This is, so last year you gave someone the flu shot and they were having hives. If that happened, that patient has a contraindication to the influenza vaccine. So it doesn't matter which one you use, you just cannot use any of them. It doesn't matter. You cannot use recombinant influenza vaccine. You cannot use inactivated, just because you don't know what exactly they reacted to, and it can cause anaphylactic reactions. So it's contraindication. Now, what if the patient is pregnant? So one thing that's absolutely contraindicated in pregnancy is the live attenuated vaccine, which is not available anymore. So it should not be a problem. But I'm emphasizing it, just in case in the future, if they bring back the live attenuated flu shot, it is contraindicated. Any live vaccine is contraindicated in pregnancy. So it's okay to give inactivated seasonal influenza vaccine to a pregnant patient. Now, what if the patient is elderly? So here's a recommendation for the elderly. They say, again, you can use any available licensed influenza shot. It doesn't matter which one you use. And the reason they say that is because they want you to vaccinate as many people as possible. Now, the reason that elderly has become its own patient population is because they found that when you give the flu shot to the elderly, and by elderly we mean age 65 and older, the antibody titers decline a few months after immunization, which means that it could be halfway through the flu season. Because when you get older, your immune system is not as strong as a younger person. The titers start to go down. So they said, okay, what if we make a flu shot specifically for the elderly with a higher dose? So if you give a higher dose, then the body can make more antibodies. That way, there are more antibodies in the body throughout the flu season. And they actually studied it. So they found that if you use Fluzone is the brand, and this is the only high dose influenza vaccine that's available on the market. It's also inactivated. It's inactivated, but it has a higher dose. And they compared it to a normal standard dose, and they said, look, there's a 24% greater relative efficacy. So that's one way to go. So you may have Fluzone high dose available in your pharmacy. So know that this is intended for patients 65 years or older. Another thing is, remember when I talked about recombinant influenza vaccine that eliminates the egg allergy? They also found that, by the way, it also has higher immunogenicity in the elderly. So recombinant not only eliminates the cross-reactivity with egg allergy, but also results in 30% greater relative efficacy in elderly. So here's another option. So Flu-Black quadrivalent is a recombinant influenza vaccine that's indicated for, they studied it in patients 50 years or older. And the last one is Fluad, which is an adjuvated, inactivated influenza vaccine trivalent. So what it does is that it's the same inactivated influenza vaccine, but they add a compound to it. So there's a compound MF59, and it's basically a squalene-based oil in water emulsion. What it does in the body is that it recruits antigen-presenting cells to the site of administration of the vaccine. It increases the binding of the antibody to the influenza virus, and it increases the immunogenicity. So this is a great idea in the elderly because of this compound. It increases immunogenicity so that the virus becomes more effective. In fact, in the one study that they have is there was 63% greater relative efficacy compared to the standard dose. Um, and by the way, this is also standard dose. So both of these are standard dose. The only difference is that you have this MF59 compound to increase immunogenicity. So here are your three options for elderly. But regardless, the CDC says it doesn't matter which one you use. Use whichever is available. You know, whether standard dose or high dose, trivalent or quadrivalent, unadjuvanted or adjuvanted or recombinant. It doesn't matter because they want you to vaccinate as many people as possible. That's the key. And here I have listed the different types, different formulations. You don't need to memorize these brand names, um, but but there are a lot of brand names. So you know, in your community pharmacy, you will likely see a lot of things, and they can be confusing because everything listed here is a flu shot. Everything here is a flu shot, so it can be confusing, you know, because flu shot sounds pretty straightforward, but if you're not careful, it can get um, confusing. So I have tried to organize. So the top one, flu mist, is the spray, the nasal spray. That's live attenuated. It's not available on the market right now because it's not recommended because of poor performance in the past seasons. Next, we have basically everything up to here is standard dose. Then you have your high dose, so Fluzone high dose for elderly. You, so amongst the standard dose, you have inactivated influenza vaccine. So there are different brands, including Fluzone. So Fluzone alone is just a standard dose. Then you have your Fluzone high dose. Um, then there's also a cell cultured inactivated influenza vaccine. The point of cell cultured was that instead of the egg, they were trying to use a mammalian cell to grow the vaccine. Again, for the same purpose of avoiding the reactivity with um, egg allergy. However, because the initial strains that they get from the CDC or World Health Organization is actually developed from eggs. So because of that, CDC doesn't consider this egg-free. So the technology that grows it doesn't use eggs; it uses cell culture. But CDC does not consider this egg-free, so it doesn't really help with egg allergy. And regardless, the CDC says it doesn't matter if the patient has egg allergy; give them whatever you have. So, and then here are your recombinant. You know, you have either trivalent or quadrivalent. Um, and then here's Flood is the adjuvanted. And then the last one is intradermal. So intradermal is interesting. Is for people who are afraid of needles. So the needle is, I mean, this one still has needle and it's intradermal, but the needle is so small. It's as thick as a penny. So roughly 1.5 millimeter. So it helps with people who are afraid of needles. And keep in mind that intradermal is different than sub-Q. So this is not a subcutaneous injection, because subcutaneous injection also has a longer needle, but this is intradermal, so it's different. And I have uploaded a video on administration technique for intradermal, so definitely check it out. All right, so next we have diphtheria, tetanus, and pertussis. So here with the abbreviation, note that the uppercase letter in the abbreviation are full strength dose, whereas lowercase are reduced doses. Now it's important to know these brand names because both Naplex and CPJE definitely ask about brand names for uh, for for important vaccines. So Tdap is definitely one of them. So expect to see Boostrix and any of these brand names on your board exam. So start to, and this is not something that you hear every day. So try to be familiar with it. Start from now. So here's the indication for the tetanus shot. So adults should receive a single dose of TD every 10 years. Definitely every 10 years. It doesn't matter who you are. If you don't have a contraindication like anaphylactic reaction to it, you should definitely get a tetanus every year. If someone has not had the shot before, you should get the first one should be a Tdap, and then after that, every 10 years, it's just a TD. So when it comes to pregnancy, there are two vaccines that are definitely indicated in every pregnancy, and it doesn't matter, it doesn't matter if when was the last time somebody got their shots. Every time someone is pregnant, they definitely need to get the flu shot, and they definitely need to get the TD. So let's say if someone got the TD like 2 years ago and they get pregnant this year, they need the TD. It doesn't matter if it's been 10 years or not. If somebody gets pregnant 5 times in 10 years, they need to get the TD 5 times, once for each pregnancy. So that's very important about pregnancy. So every time somebody gets pregnant, definitely a TD, and then the influenza shot, which by the way, influenza cannot be live attenuated vaccine. All right. Next, we have herpes zoster, or the shingles vaccine. Definitely is indicated for patients 60 years of age or older. Just a single dose. Now, it is FDA approved for ages of 50 and older, but the CDC really doesn't recommend it until you're 60. So, if somebody wanted to ask for it if they're like 55, they could, but just know that CDC is not recommended. So then it depends on if your insurance didn't want to pay for it because CDC doesn't recommend it, they could. So it just depends. This is an example of a live vaccine, so it's definitely contraindicated in pregnancy. It's also contraindicated in severe immune deficiency, including immunosuppressed patients with CDC, or if they have a HIV with CD4 count less than 200. Zostavax is the brand name, so definitely try to you need to know the brand name for herpes zoster, which is easy to remember. Zostavax, zoster. Oh, and you need to keep it in the freezer. So any live vaccine, you need to store it in the freezer. So once you take it out of the freezer to use it, it needs to be used within 72 hours. So if you removed it from freezer and you put it, someone wants to get it and then they couldn't pay for it, but you took it out of the freezer already and you put it in the refrigerator, you gotta use it within 72 hours. After 72 hours, you gotta throw it away. Next we have the HPV vaccine. Now, this is a little, it gets a little complicated, but just focus on what's bolded here. So, for females and males. So, for females, definitely once they're an adult through age of 26 years, if they've never had this vaccine before, they should receive a 3-dose series. So, this is a strong recommendation. Now, when it comes to males who've never had it before, as an adult through, so 18 years through 21 years, they say you should receive a 3-dose series. And then after 21, so 22 through 26, that matches the female version. For females, they should receive it, but for males, they say you may receive it, so it's optional. The data is stronger with females. And then we only have Gardasil is a non-valent HPV, so it has 9 versions of the HPV. There's also, I don't think it's available on the market anymore. Last year we had it. It was just Gardasil without the 9, and it only had 4 valent. It was a 4-valent HPV. What I think the one that's currently on the market, because I didn't see the other one, is just the Gardasil 9. So you will only see this one by the time you go on rotation. And here's why this isn't important. So, there are 4 types of HPV that will cause about 70% of the cervical cancers, and you can see all these stats, like 90% of genital warts. And then there's 5 other HPV types that cause, other types, same types of cancer. But together, all of these 9 types of HPV will cause around 80 to 90% of these cancers. So that's what makes this vaccine a very good vaccine. So you can actually prevent many of these cancers, including genital warts. So. Next, let's have an introduction to meningococcus and pneumococcus. So, when people say meningococcal disease, what they really mean is meningococcal meningitis. So, when they say meningococcal, they're referring to an organism, bacteria called Neisseria meningitidis, and Neisseria meningitidis can cause meningitis. So people may not refer to the name of the organism Neisseria, so because Neisseria meningitidis, people just say meningococcal. So be familiar when people say meningococcal, they're referring to this organism, and this organism, the most common infection that it causes is meningitis. So when people say, okay, you're getting a meningococcal vaccine, it's really vaccine for meningitis. So it's a meningitis shot. Now, with this organism, because it has it comes in 12 different serotypes. So worldwide, here are the common serotypes. So A, B, C, W, X, and Y. Now in the US, B, C, and Y are the most common one. Now it's important to keep this in mind because when it comes to the actual vaccines, we have, generally speaking, we have 2 vaccines because the third one has been discontinued. Earlier this year, it got discontinued. So we have 2 types of vaccines now. We have one that has serotype ACWY, and then we have just, serotype B, men B. So we have 2 brand names for each of them. So it's important to know these brand names because, again, CPJE and NAPLEX do like to ask about these brand names for meningococcal. Now, that was meningococcal. Then you also have pneumococcal. So this becomes confusing because they sound alike, meningococcal and pneumococcal. So when you say pneumococcal, they're talking about an organism called Streptococcus pneumoniae. Streptococcus pneumoniae. So anytime somebody says, pneumococcal shot, they're talking about Streptococcus pneumoniae. So meningococcal means Neisseria meningitidis. Now here's the problem. Strep pneumo, for short, strep pneumo or Streptococcus pneumoniae. Strep pneumo can cause many diseases. The 2 common ones are meningitis, and they can also cause pneumonia. So the most common cause of pneumonia, which is a pulmonary infection, is Streptococcus pneumoniae, strep pneumo. So now you cannot say this is a, especially a lot of people say this is a pneumonia shot. Sure, because it can cause pneumonia, but people forget that it can also cause meningitis. So when you get your pneumococcal shot, not only are you trying to prevent pneumonia, but you're also trying to prevent meningitis. Another way of thinking of it is, when you're trying to prevent meningitis, you need both of these because it's not just one organism causing meningitis. So if you're trying to prevent meningitis, you need a meningococcal vaccine, and you also need a pneumococcal vaccine. So strep pneumo also has a capsule. It has an outer capsule that causes different serotypes because there can be variations in the capsules, and the body will react to those capsules. That's how your immune system will detect it and build immunity. So it's a matter of how many of these capsules can you include in your vaccine. Which brings us to the two available. We only have two pneumococcal vaccines available. One is a Pneumovax 23, so it has 23 different strains in it, whereas another one is called Prevnar 13, which only has 13. But there are some very important differences between these two, a lot more than just the number of strains. And then in this pyramid, I'm just showing you that Streptococcus pneumoniae is a common organism. It's referred as a, we call it a respiratory. We call this a respiratory pathogen because it usually infects the respiratory tract. So the most common infection it can cause is pneumonia. So, and then they say that sometimes pneumonia can also get into the blood. So that's why they're saying most of it is non-bacteremic pneumonia, and then it can also get into blood. So that's where the problem comes. So once it gets into the blood, it can go anywhere, so including to the brain, and that's how you get like also, it's not as common as pneumonia, but still a serious threat because meningitis can kill you. So strep pneumonia can also cause meningitis. Now here, let's talk about meningococcal vaccination first. So for meningococcal, here are the indications. So the spleen. If someone doesn't have a spleen, we call this asplenia. And it could be either anatomical, as in somebody's spleen was removed, surgically removed, or for whatever reason they don't have a spleen, or if it's not functional. So even if they physically have a spleen but it doesn't work, one common example is if someone has sickle cell disease, sickle cell disease causes people's spleen to stop working, and we call that a functional asplenia. But regardless, if someone has asplenia, that's when the meningococcal vaccine is recommended. So a 2-dose series, and they need to be at least 2 months apart, and then they need to be reactivated every 5 years. And the reason for this is, those meningococcus and pneumococcus, they are capsular, and the spleen is actually responsible for clearing the bacteria. Those bacteria in particular, so strep pneumo and Neisseria meningitidis, the spleen can remove them. So if somebody doesn't have the spleen, then they are at risk for getting infected. That's why if someone doesn't have the spleen, it's recommended that every 5 years they need to get this 2 doses. Okay. And then in addition, they say also get one time 2-dose series, depending on the brand name, either a 2-dose series or 3-dose series of this serogroup B. But with serogroup B, there is no need for revaccination every 5 years. Another indication is also HIV infection. So someone who has HIV infection, because of their immune system, it's recommended to get the ACWY. and revaccinate every 5 years. Now, it's not indicated to get the B serotype just because in HIV infection it's not common. And here are some other, less common indications for meningococcal. But I want you to focus on asplenia and HIV infection. I know that asplenia, that includes sickle cell disease. Now, here are the pneumococcal vaccination recommendation. Actually, before I talk about the recommendation, let's talk about the differences between the two. So the Pneumovax has 23 different strains, whereas the Prevnar has 13. So it sounds like 23 is a lot better than 13, right? Now, there is a reason that there are 23 and only 13 here. First of all, the PPSV stands for pneumococcal polysaccharide vaccine, whereas the PCV is the pneumococcal conjugate vaccine. So the polysaccharide is a saccharide. So if you consider your, from biochemistry, your macromolecules, the saccharides are a lot, smaller than this conjugate is. The PCV is conjugated to proteins. So these strains are conjugated to proteins, whereas these are polysaccharides. So polysaccharides are smaller than proteins. That's why you could include a lot more strains in the polysaccharide version, whereas the conjugate vaccine, because its protein is bigger, they could only fit 13 strains so far. So in the future, they may be able to get more in there, but that's why you have a smaller number here. But you may ask why. So the way that the body reacts to these vaccines is that it's proteins are more immunogenic than polysaccharide, especially at a younger age. So when someone is younger than 2 years of age, they are unable to build immunity to these polysaccharides, whereas to a protein they can. So that was the first reason to do this. They said, okay, look, we conjugated this to proteins, and it actually worked in children younger than 2 years, and it was a very strong immunogenicity. And the other thing is that this is also true in the elderly. So in 65 years and older, you get a stronger immunogenicity from the PCV13. So yeah, it turns out that PCV13 is actually a better vaccine, even though you have fewer strains. So 23 is a lot more, but you get a better response from this 13. Now, in clinical trials with PPSV, they've actually never proven that it can prevent pneumonia. Whereas the PCV13, it's proven that it can actually prevent pneumonia. So if PPSV23 has not been proven to prevent pneumonia, you might ask, then why are we giving it? And that's because meningitis. It actually works for preventing invasive pneumococcal infections like meningitis. So and that's very important. So this is not something that you want to tell your patient. Do not tell your patient that this doesn't prevent pneumonia, because patients may not understand that this is so much more than a pneumonia shot, because it can prevent meningitis. But definitely PCV13 has been proven to prevent invasive and non-invasive infections. Now let's look at the recommendations. So let's talk about PPSV23 first. So not everyone needs the PPSV. So a healthy person does not need it. A healthy person does not need it. But if someone has comorbidities like chronic heart or lung disease, diabetes, alcoholism, or chronic liver disease between the ages of 19 to 64, then they should get one shot of PPSV23. And then once they're 65, everybody, it doesn't matter who it is, anybody who turns 65, they need to get one dose of PCV13. PCV13 definitely been shown to prevent pneumonia and invasive pneumococcal disease in elderly. So, whether healthy or comorbidities. Once someone turns 65, you need to give them a PCV13. Now the question is, before they turn 65, if they had an indication for PPSP23 and they got one, you need to wait at least 1 year before you give the PCV13, which is usually not an issue. Let's say somebody gets it at the age of, you know, 25, and then once they're 65, they get PCV13. But if they, at the age of 64, they got PPSP23, you need to make sure, what if they were 64.5 years old? You need to wait at least 1 year to give the PCV13. And then a year later after PCV13, for those who are 65 or older, then you give a PPSV23. So these two, for ages of 65 and older, is for everyone. It doesn't matter if they have, if they are healthy or they have comorbidities. This is for everyone. But you give the PCV13 first, and then a year later you give the PPSV23. And that's because PCV13 is a more important vaccine. So you give this one first, and then a year later you give PPSV23 to get those additional strains. But you want PCV13 first because it works better. It's a better vaccine. But then, so for these people, 19 to 64, it's only if they have an indication like these comorbidities. So if someone is healthy and doesn't have these comorbidities, they don't get anything here. But once they are 65, they get the PCV13, and then a year later they get PPSV23. Also, for those who had to get the PPSV23 between 19 and 65 years, there has to be 5 years between the two PPSVs. So let's say if they got PPSV23 at age 64, you give them a PCV13 at age 65, and then the next one, the PPSV23, needs to be 5 years after this, so it will be at age 69, because there needs to be 5 years. So even though it's been a year after PCV13, it also needs to be 5 years after the PPSV23. Now that was who exactly needs to get PCV13 before the age of 65, because I said everybody gets it at the age of 65. So now here are some indications for people who need to get PCV13 before they are 65. So this includes if someone has cerebrospinal fluid leaks, so if someone has cochlear implants in their ear, so if they have implants, sickle cell disease, and also if they have some sort of problem with their spleen. The same with sickle cell disease, it messes the spleen, and also HIV infection. Other indications includes chronic renal failure, nephrotic syndrome, leukemia, lymphoma. Don't worry about these too much, but focus on the CSF leak, cochlear implants, definitely sickle cell disease, and asplenia and immune deficiencies like HIV. But anyway, if you have one of these indications, you get one PCV13 first. So this is the best vaccine we have for pneumococcal. So you give this first, and then you're not gonna wait a year, because these people, they are immuno deficient, or for whatever reason, they really need it. So you're gonna wait 8 weeks rather than a year, and 8 weeks later you give them PPSV23, and then 5 years later you give them another one. You're not gonna wait till they're 65. So so prior to 65, you do one PCV13 and two PPSV23s, and they need to be, the PPSV23s need to be 5 years apart. Okay. The only thing different is that PCV13 needs, 8 weeks later you do the PPSV23. Now, once they're 65, you go back to your general recommendations for the 65. Because they got their PCV13 already, you do not need to give it again on, once they're 65, and it's because this is a conjugate vaccine. So this is conjugated to protein, so it has a strong immunogenicity. So by the time they're 65, the immune response will persist. You do not give it another one. But PPSV is a polysaccharide. The immunogenicity is not strong. That's why we're giving multiple. The body does not, react strongly to this. That's why we give two. And by the time they're 65, you need to do another one because this is a polysaccharide. But the PCV is a conjugate, so immunogenicity is strong. You don't need to give another one. Once you give it, that's fine. And this is what I actually explained earlier. So for a general population, someone who's healthy, once they're 65, you just give them a PCV 13, and then you give them a PPSV 23. Now, if they had some medical conditions like if they were immunocompromised because they really need it, because they don't have an immune system, you're not gonna wait a year, so you just give them 8 weeks later. That's the only reason for this difference between 8 weeks and 1 year. So if someone really needs this, you're not gonna wait a year. You just give it as soon as possible, which is 8 weeks. Otherwise, people just wait a year. Another reason, a lot of these 1 years is because of um, prior authorizations, especially with Medicare, because when it first started, if you were trying to do this like 8 weeks, you had to call, the pharmacy had to call a lot to get prior authorization because you're trying to give two, you're trying to authorize two pneumococcal immunizations. To prevent that, they said, okay, just wait a year. But if someone really needs it, you're not gonna wait a year. Just call and get the prior authorization. We'll just do it, in 8 weeks. So that's the explanation. So nothing else is significant about 1 year versus 8 weeks. All right, and then lastly, they have color coded the recommendations in the schedule. So, and this is something that's really important. So you should be familiar with these schedules and how to use it. And we'll talk about this in class on how to use these schedules. Our last learning objective is identify true contraindications to administering a vaccine. So, anaphylactic reactions to any vaccine is a contraindication to it. Egg allergy, so yellow fever vaccine has some components of egg, so it should be avoided in patients with egg allergy. That's the current recommendation. Now, one thing that we used to say was, some flu shots also have egg components. So, a couple years ago, it was that if someone had egg allergies, giving flu shots that had egg components were contraindicated. Now, that recommendation changed last year. So the recommendation for vaccination of people with egg allergies changed for 2016-2017, and they said that people with egg allergies can receive any licensed recommended age-appropriate influenza vaccine and no longer have to be monitored for 30 minutes after receiving the vaccine. Now, people who have severe egg allergies should be vaccinated in a medical setting and be supervised by a healthcare provider who is able to recognize and manage severe allergic conditions. So, but no contraindication nonetheless. Now, for patients who had encephalopathy within 7 days of previous dose, DTaP or Tdap is contraindicated. Pregnancy, of course, any live vaccine is contraindicated, including HPV and MMR. For immunocompromised patients, also live vaccines are contraindicated, and untreated active TB, also live vaccines are contraindicated. Some precautions, so mild illness with or without fever, for example, common cold, Vaccines may be administered if the provider and parent or patient deems the benefit of vaccination to outweigh the risk to a person who has a moderate or severe acute illness with or without fever. Of course, always use professional judgment when it comes to that. That concludes this presentation.